Hello and welcome to this episode of Premier Pain Talk. I'm your host, Dr. Michael Danko. I'm with Premier Pain Treatment Institute in Cincinnati, Ohio. We have four locations in the greater Cincinnati area, primarily on the northern and eastern sides of the city. We have our ambulatory surgery center, Premier Surgical Institute, and we are kicking off this podcast episode as a way to, I think, target a little bit different audience. So the audience I want to target today is really a newer provider to pain management. However, I think a lot of people in chronic pain can get a lot of value out of this podcast as well. Maybe some advanced providers that have been doing this for a while, maybe even longer than me, might maybe they'll pick up a nugget or two. So what we're going to do today is I'm going to talk through seven of the main basic procedures that we do in pain management. I'm going to break them down individually into kind of segments about each one, and then we'll kind of wrap it up at the end. But as far as this is my interpretation of these procedures and how I've done them over 12 years of doing pain management. This have to always give that disclaimer. This is not medical advice, and if you're a provider out there, you need to use your own discretion and medical judgment on how to do these things properly. And if you're a patient, obviously talk to your specific provider about how they're going to do it and what to expect. So with that, we're going to kick into the first topic. I'm going to talk about epidural steroid injections. Epidural steroid injections are quite possibly the most common procedure in pain management. They can be done for the cervical spine, the thoracic spine, and the lumbar spine. That's basically the neck, the mid-back, and the low back. Most commonly for the low back, so about 80% of people will see some kind of healthcare provider at some point in their life for low back pain. So, if you make your way down to a pain management specialist, it's very possible that the reason that you're in pain may be able to be treated by an epidural injection. This is very different than an epidural for pregnancy. So an epidural for pregnancy is infusing a whole lot of numbing medication into the epidural space in the spine to block labor contractions. We're not trying to do that. We're trying to alleviate inflammation and pain in the that area of the spine that we're looking to treat. As far as reasons to do this procedure, there are kind of two primary indications for the procedure. The first one is something called radiculopathy. So that is a condition where a nerve root in the spinal canal is getting compressed and it's causing pain to radiate down an extremity. So either the arm or the leg. If it's in the thoracic spine, that people will kind of describe it wrapping around to their chest or their abdomen. But that is a kind of follows something called a dermatomal pattern. So it's a pattern where the nerve travels in a fairly classic pattern down the extremity or across the torso. And based on the pattern, a lot of times clinically you can try to get an idea of what level or possible levels are involved. For instance, if we're talking about the upper extremity, talking about the arm, pain that refers down to the thumb is generally considered to be like C6. If it goes into the index finger and middle finger, that's C7. If it goes into the ring finger and the pinky finger, C8. If you're going down the leg, going to the top of the knee, a lot of times we think that is L4. Going around to the top of the foot or the big toe being L5. The rest of the toes or the bottom of the foot it'd be S1. And those are a few examples of how we can use our clinical symptoms the patient is talking about to help us guide where we think we might be needing to look on our imaging when we're trying to figure out what the plan is. There are different approaches for epidural injections. The interlaminar approach to the epidural injection is when the kind of going right down the middle into the we call the interlaminar opening. This is generally a single injection site, so numb the skin, advance needle down to the epidural space, confirm that you're in the space with some contrast dye, and then put the medication in. The other approach is the transforaminal approach. This is approach coming more from an oblique angle to access the neural foramen on whichever side you're going for, or sometimes one on each side. This is a procedure that can potentially more selectively deliver the medication to an individual nerve root or two nerve roots. That's why sometimes a transforaminal epidural is called a selective nerve root block. The same kind of concept, put contrast dye in to make sure the spread is appropriate, and then put in the medication. What medication are we typically using? This is going to be a corticosteroid. There are a lot of different options. The one option that we use in our practice most commonly is called dexamethasone. That is something called a non-particulate steroid. So it's, theoretically a little bit safer in terms of if it would accidentally be injected into an arterial supply, blood vessel. And then as far as the what else will you put with it? Generally, you could put just saline in with it, just get a little more volume and a little more spread of the medication. Or instead of the saline, or in combination with the saline and the steroid, some people will use a local anesthetic to try to get more immediate relief. And so, if a local anesthetic is involved, then what you're trying to do is just get more immediate relief for the pain while that steroid is kicking in. And typically, we tell the patients it could take up to 72 hours or 3 days before that steroid really starts helping, and it may take up to 2 weeks to really start to see benefit from the injection. So the reason why a local anesthetic may not be injected, and that typically I do not include in the epidurals in my clinic, is that a couple of reasons. You would never use it in the cervical spine, because you risk any kind of respiratory depression or a spinal block happening for remember from school, we say C3, 4, and 5 keep the diaphragm alive. So you don't want to numb those nerves and have the patient start having breathing problems. In the thoracic or the lumbar spine, if you would accidentally go too deep with an interlaminar epidural and accidentally go through the epidural space into the intrathecal space, what we call a accidental dural puncture, then that local anesthetic in that area will cause a spinal block, and then the patients can have heavy legs for a few hours while they're waiting in clinic to go home. So in general, while there's a lot of obviously benefit to getting the patients more immediate pain relief, if it's going to delay potentially delay their leaving the clinic in a scenario of an unintentional dural puncture, then a lot of times that's can be pretty disruptive to both that patient's life for the next several hours and clinic flow, depending on, especially if it would happen later in the day. So as far as the transforaminal approach, I want to quickly mention that is typically only performed in the lumbar spine. Some providers will do cervical transforaminal injections in the transforaminals in the neck region of the cervical spine. It's a higher risk procedure, so it's not as commonly performed. There's also one more specialized type of epidural that can be done for the lumbar spine. That's called a caudal epidural. So with that, it'll approach from the bottom of the sacrum, or we call the sacral hiatus, which is a way to access the epidural space that way. So if a patient's had a previous lumbar spine surgery with a posterior approach, and they have scar tissue and other things going on back there where you can't get, it's really either unsafe to access due to the scar tissue, or you have difficulty accessing because of the scar tissue or some of the like bone matrix that might have been put in when they're potentially doing something like a fusion. Then the caudal approach can be good for getting medication up into that epidural space, kind of coming from an inferior approach and injecting upwards. It's also I will typically use transforaminal injections for patients who've had lumbar surgeries in the past. So interlaminar, I think, is just a higher risk for an unintentional dural puncture and spinal headache, than because of that scar tissue from the surgical dissection. So in general, transforaminals I think are the best for lumbar for patients with previous back surgeries. But ultimately, again, like I mentioned at the very beginning of the episode, it's all about provider discretion and technique. As far as one other indication for epidurals, because kind of doing this off the cuff, so I unfortunately missed this earlier on. The other indication is something called spinal stenosis. So spinal stenosis is a narrowing of the spinal canal, and there can be multiple reasons why this can happen. But ultimately, this is I kind of think about spinal stenosis like a clogged drain. So If you're trying to brush your teeth and the water's backing up into the basin of the sink because of clogged back there, that's kind of like stenosis. There's not enough room back there, and so when the patient's trying to stand and walk, they often will have either increased back pain or leg pain, or they'll start to have numbness or heaviness in their legs, and they feel like they just got to sit down. And so the reason for that is when you sit down or when you lean forward on a shopping cart, sometimes we'll call it look for like the shopping cart sign. People are flexing they're opening up that spinal canal more. They're giving themselves a little more room, giving those nerves a little more chance to breathe. And then when they lean back or stand up, what you're doing is you're extending the spine, and then you're kind of closing that down further. And so spinal stenosis is, an issue of not enough space. And so when you have a more mild or moderate stenosis, that a lot of times those patients can respond to epidural injections, but sometimes or oftentimes as the stenosis progresses and becomes more significant or more severe, then epidural injections will have a kind of a declining efficacy. Um, so I kind of think, I love analogies, and I kind of think of stenosis and epidurals as kind of putting the Drano down and putting some chemical in the drain to see if you can kind of flush it out, getting it flow a little better. So obviously, anybody who's had to DIY a drain in their house, knows that sometimes Drano works, sometimes you got to take that drain cap off and see if there's a clog you can get yourself, or sometimes you got to call the plumber. So this would be step number one of putting some Drano down there and seeing what happens. So with that, last thing I'll kind of mention is with a couple of physical exam findings. When you're talking about the cervical spine, one indication that can be some nerve root compression going on is something called the Sperling's maneuver or Sperling's test. That can help with in the diagnostic workup. In the lumbar spine, typically the test that we're among others that we're looking at is the straight leg test to assess for nerve root compression. So you take their symptoms, see if it's a radicular pattern, or see if it sounds like stenosis. See if you're finding some of those exam findings that would correlate with it, and then looking at the advanced imaging, an MRI or a CT scan, and confirming where the issue is. Have the patient do 6 weeks of conservative treatment. And if that doesn't work, and the advanced imaging is showing an indication for an epidural, then you get them set up for the epidural. So with that, we're gonna take a short break, and then we're gonna move into the next topic. All right, we're back to Premier Pain Talk. I'm Dr. Michael Danko. Next topic I'm going to talk about procedurally is something called medial branch block, or sometimes called facet joint injections, depending on what approach you're taking and what you're injecting. These are treatments for the spine. They are primarily for joint pain within the spine. These joints that we call facet joints that allow us to bend and twist and do other movements with the spine. Like any other joint, they can get arthritis in them. And so there are kind of two main approaches to try and treat this arthritic joint pain in the spine. The first approach would be something called a facet joint injection. So this is a corticosteroid injection into the joint. These are very small joints. You put a little bit of steroid in there with a little bit of local anesthetic and try to get some more immediate relief. And similar to something like an epidural injection, this is a therapeutic injection, so you're trying to see if with a steroid, can you provide what length of relief can you provide? Can you provide 3 months or 6 months or more of relief where it would make sense to potentially treat these intermittently, similar to also like you might do with a joint injection. As far as if either facet joints don't last long enough, or you decide that you want to kind of skip over the facet joint injections, either due to concerns about steroids or want to kind of move towards a potentially more durable option, that's when you'll be considering medial branch blocks. So medial branch blocks can be done for the cervical spine, for the thoracic spine, for the lumbar spine. They're most commonly for the lumbar spine because low back pain is just such a common indication for pain conditions. And what you're going to do is you're going to look under X-ray, and you're going to block the nerves that are carrying pain signals from the joint. So you're not these little nerves are not the nerve root like you're treating with an epidural injection. They're a branch off of it called the medial branch nerve. And so these medial branch nerves supply the facet joints, and so when you're having pain from those joints, if you can block those nerves, you potentially can prove that the pain is coming from those joints. So look under X-ray, inject some, place the needles at each of the locations. Typically, most common joints that are going to develop arthritis in the lumbar spine are L4-5 and L5-S1. In the cervical spine, it's going to be C5, C6, and C6, C7. And there are kind of confusing, but there are three nerves carrying signals for two joints, or two nerves for one joint. And so basically, if you were going to do, for instance, a medial branch block for the L4-5 and L5-S1 facet joints, you're going to order, that's going to be L4, L5, S1 getting blocked. And so, for the when you're kind of explaining this procedure to the patient, there's going to be typically, two or three injections in each side that you're doing. And so numb it up really good. Place a spinal needle down at the junction of the articular process and the transverse process where the medial branch nerve runs, and then can inject a local anesthetic to block that joint. And so typically, most people will use bupivacaine for this because it's going to be a little bit longer of a blockade, potentially up to 24 hours of relief. Some physicians will choose to do lidocaine or other local anesthetics that may potentially have a little shorter duration of action. But what we're trying to figure out is, for the time being where those joints are numbed, how much of the pain goes away. And then reason you're doing this test is you're trying to see if the patient's candidate for something called a radiofrequency ablation. And so the radiofrequency ablation is there are different ways to do an ablation, but for facet joint pain in the spine, you're going to be doing primarily something called a thermal ablation, where you're heating the joint, and the nerve to 80 degrees Celsius for at least 90 seconds, to create a lesion that's going to potentially stop pain signals coming from that joint for at least 6 to 12 months, sometimes longer. Insurance typically will require two of these injections, so the medial branch blocks to qualify for an ablation. So when you're talking to the patient about this, you're gonna say, okay, we're gonna do this nerve block for your facet joint pain in your back, and then if it works really good, we're gonna do it a second time to confirm that that's where the pain's coming from. And then if both the initial diagnostic and the second confirmatory blocks are successful, then we'll move forward with the ablation procedure. So a little bit clinically speaking, how are we trying to identify facet joint pain in patients? And typically, the facet joints that are hurting will be tender on palpation. So your physical exam can help kind of guide where they're, based on what they're saying, where they're tender. This pain is often exacerbated by loading the joints. So extending the spine and rotating it to the painful side will often provoke be provocative test. We call that facet loading, cause pain. The pain pattern can be helpful. So typically this is not going to have a radicular or dermatomal pattern to it. The pain may not radiate at all, or maybe kind of radiate just to the hips or the back of the knee. And imaging, you're gonna want to see some changes to the facet joints, indicating arthritic changes to the joints as well. And so sometimes that'll be called facet arthropathy. Sometimes they'll talk about osteophytes. Sometimes the radiologist will talk about spondylosis. These are all kind of buzzwords or indications for facet joint arthritis, or as a potential source for the pain. Diagnosis most commonly is going to be using that spondylosis diagnosis. So in the cervical spine, you'd be using cervical spondylosis. In the thoracic spine, you'd be using thoracic spondylosis. And lumbar spine, lumbar spondylosis. And then, like I mentioned before, you're going to want to see that conservative treatment has been done for this condition. The conservative treatment is typically like 6 weeks of physical therapy, or a structured home exercise program, or chiropractic care. You're going to want to at least have some plain film X-rays of the joints, and then generally you can get approval for the procedure at that point. And then, like I mentioned, the facet joint injections, if you're going that route, that's really intended to be the therapy. So the steroid you're injecting in the joints is intended to provide the duration of relief for the patient. If you're doing medial branch blocks, then what you're doing is you're doing a diagnostic or test procedure to see if they're going to be candidate for the radiofrequency ablation, and the ablation is going to be the long-term treatment in that regard. All right, so with that, we're going to take another break, then we're going to actually go into talking more detail about radiofrequency ablation and other indications for it beyond just the spine.
At Premier Pain Treatment Institute, our patients always come first. Our board-certified physicians are experts at the treatment of chronic pain caused by various medical conditions, including cancer. Our goal is not only to relieve your pain, but to restore your quality of life. With locations in Hillsborough, Loveland, Middletown, and Mount Orab, there's always a location near you. We accept nearly all insurances, including Medicaid. Call us today at 513-812-PAIN or visit us online at premierpaintreatment.com.
All right, we're back on Premier Pain Talk. I'm Dr. Michael Danko, Premier Pain Treatment Institute, and we're going to be talking about radiofrequency ablations. So, radiofrequency ablation has a few different names to it. So, depending on what name you hear, you could potentially all be talking about the same thing. So, we will oftentimes that is quite a mouthful to say radiofrequency ablation. Try saying that 5 times fast. So instead, we'll often refer to it as an RFA, so radio frequency ablation, RFA. In layman's terms, is very commonly called burning the nerves, or sometimes it's called a neurotomy. And what you're essentially doing here is you are using a impulse to block nerves from sending signals, and typically in our pain world, we're trying to stop pain signals. And so there are three different types of ablations. There's very most common type of ablation is a thermal ablation, but there's also a pulsed ablation. There's also a cooled ablation. With as the names kind of imply there, at least for the first and the third there, thermal ablation is a generating heat. So generally, there's different settings, for different targets, and the most common settings probably, at least that I like to use, there's a 80 degrees Celsius ablation for at least 90 seconds in duration. And a pulsed ablation is actually a slightly above body temperature, so it's 42 degrees Celsius, and that's typically a little bit longer ablation. It's for 120 minutes, 120 seconds. 120 minutes would be a really long time. But the pulsed ablation is generally done for nerves that have a combined sensory and motor component to it. So you don't want to thermally ablate or burn a nerve that has motor function to it, because then you'll have unwanted weakness in that area, because you're not only knocking out the sensory component, which is carrying the pain signal, but you're also be knocking out the motor component that's kind of, that you would definitely want to leave intact. The third kind of ablation is something called a cooled ablation. This is kind of used in specialized conditions where you want to have a bigger lesion or bigger area that you're trying to burn or ablate to make sure you get the nerve. And like the word cooled implies, it's using cold temperatures. So typically, this is done in an ambulatory surgery center with some specialized equipment where you can generate a cooled RF. And I would say the most common use for this is around the knee. But like I mentioned, it's has to be done in a surgery center or hospital in most settings, and then typically, reimbursement or insurance coverage for it is quite challenging, because a lot of times it's viewed as experimental. As far as why we do ablations, so these are primarily for joint pain. These can be done for peripheral nerves for primary neuropathic problems as well. That's probably the second most common reason we do it. And then outside of our pain world, there's a whole host of other reasons that other specialties will do ablations. A lot of people have probably heard of a cardiac ablation, which is quite a bit different. But as far as the joint pain indications, the very most common joints that we're going to be doing ablations for are in the spine. So lumbar facet joint ablations are definitely our most common indication for it. In that we're burning the medial branch nerves. The medial branch nerves supplying the facet joints do not have a motor component. It's only sensory, so you can do a thermal ablation with that. And then moving up the spine, you can do it for thoracic facet joints. You can do it for cervical facet joints. And thoracic facet joint pain is by far the least common of those three because with the ribs connecting around to the sternum and kind of forming a cage for your thoracic spine, there's not nearly as much movement as there is with the cervical spine or the lumbar spine, which are far more mobile segments. Um, and within the kind of axial skeleton there, the other area that we're commonly doing ablation for or we used to do it a lot more in the past, but can still do some now, is for um, occipital. So this is these nerves that will come up the back of the skull, but they're really extensions of the upper cervical spine. And then SI joint ablations or lateral branch ablations. Both of those two categories I think are fantastic therapies, but they have a lot of insurance companies have decided to make them experimental or investigational. I guess the studies that they've looked at or the lack thereof for those procedures have resulted in scenarios where coverage is not nearly as universal as treatment for the cervical spine and lumbar spine. Moving outside of the axial skeleton, and we're targeting more peripheral nerves. The knee is a very common target, and with that, we do something called a genicular nerve ablation. For the shoulder, we'll do a suprascapular nerve ablation. Suprascapular nerve does have a motor component to it. So, like I mentioned earlier, this would be a target for a pulsed ablation most commonly. And then there are, other areas like the intercostal nerves. So if somebody has persistent pain from shingles, from their, intercostal neuralgia, this is a potential ablation target. The cluneal nerves. So the cluneal nerves are nerves that run across the pelvis, and those can be ablated as the kind of a less common diagnosis for low back pain. That's kind of in the back of the hip on one side or the other. And then there's a whole host of other peripheral nerves that can be blocked: ilioinguinal neuralgia, genital femoral neuralgia, etc. But essentially, to kind of recap what that procedure is, this is a procedure to stop painful signals coming from the source of the pain. There are generally two diagnostic blocks. They're going to happen beforehand to make sure that you're going to do the ablation on the proper target. If both diagnostic and confirmatory blocks are successful, then you do the ablation. Depending on what type of ablation, depends on what settings. Generally, it would take a week or two for it to kick in and really start to relieve pain. And then generally, you're looking for at least 6 to 12 months of relief. We were part of a larger study done called the RAPID study that has shown that this is on average reducing the pain in this area from on average 7 out of 10 down to a 2 out of 10, and showing extended relief as far out as we studied out to 24 months on patients. So this is a very repeatable, like I mentioned, this procedure generally lasts 6 to 12 months, but it's repeatable. So, your body doesn't really get immune to a heat signal like that. So you can do the ablation again and extend that relief. And we showed in the RAPID study that the repeat, treatments are also successful because these patients were continuing that pretty significant duration of pain relief out for the full 24-month period that we studied them in that study. So we're going to take another break here and then queue up the next procedure target. Hello and welcome back to Premier Pain Talk. I'm your host, Dr. Michael Danko. We are going to be talking about sacroiliac joint injections. So the sacroiliac joints, what are they? They are joints. You have one on each side that where the sacrum, or the very bottom of the spine, connects to the pelvis, or the iliac wing of the pelvis, to be more specific. So the sacrum, the joint between the sacrum and the ilium, is the sacroiliac joint. What this joint does is that your shock absorber. So it takes the when you're, moving, getting in and out of a chair, when you're standing, when you're walking, it's loading taking the forces from the axial skeleton and shock absorbing or offloading some of that as it goes down the extremity or down the leg. And so these are joints. They generally hurt because they move. They don't have much movement to them. There's only about 7 degrees of movement in the sacroiliac joints, but that's definitely enough to generate pain. And SI joint pain is typically is a very common source of low back pain. The studies are pretty variable on the actual incidence of SI joint pain, but a pretty easy rule of thumb is that about 25% or about a quarter of cases of low back pain are due to the SI joints. Uh, as far as treating these SI joints, just like most other joints in the body, the most common approach to this is an injection into the joint, and then most commonly what you're injecting into the joint is corticosteroid. And oftentimes some local anesthetic along with it to get some more immediate relief. So we're doing this procedure. We're looking for patients who got pain in their low back, kind of going into their hip. This pain is going to radiate oftentimes to the back or the side of the knee. There's something called the Fortin's finger test, which the patient will point to where their pain is, and if it's pretty much overlying the SI joint, then we'd call that a positive Fortin's finger test. There are 5 different, physical exam tests that you can do for the SI joint. And then generally for the specificity and sensitivity are both very high for SI joint being the culprit if at least 3 of those 5 tests are positive. So there's something called the Patrick's test. There's a compression test, distraction test, and there's Gansling's maneuver, and then that Fortin's finger test. And so generally, a lot of insurance companies won't really use that Fortin's finger test as one of the 3 they want for approval. So generally, you're looking for at least 3 of those, but between the Patrick's test, the compression test, the distraction test, and Gansling's maneuver. Obviously, how to do those exam techniques can be a little bit challenging to do in a podcast setting like this. So I would just suggest, looking up on YouTube and or on Google or whatever search engine you like to use and seeing how those tests are performed. But patients, you want to make sure they've done conservative treatment. So typically that's going to be 6 weeks of physical therapy or a structured home exercise program or chiropractic care. Alignment, corrections from the chiropractor are actually pretty effective for SI joint pathology. Physical therapy has some good data for SI joint pathology. You're kind of stabilizing that pelvic girdle and that really improving the strength of the muscles that really helps. But when those are not working, not lasting long enough, and then you'd move on to an injection of the joint. So a lot of times imaging isn't necessarily required if you have the appropriate physical exam findings. The gold standard for diagnosing SI joint pathology is to inject the joint and see if, when there's local anesthetic in the joint, see if the pain goes away. There's, like I mentioned earlier, there's very little movement to this joint. So sometimes when you're looking at the joints on imaging, it's not going to be too remarkable. There's not going to be really, oftentimes not a significant amount of arthritic changes going on in the joint that would be able to be seen via imaging. But we do the joint injection. We do this with most commonly with fluoroscopic guidance. There are some out there that would do this with ultrasound guidance, but most common imaging modality is going to be fluoroscopy or X-ray guidance. Going to do something called the river view, where you're adjusting the view of your machine to see the joint line, see the opening. Numb the skin up really good, place a needle inside the joint, inject some contrast dye so you can confirm that your placement is appropriate inside the joint. Take a couple of different X-ray views to help clarify that you're inside the joint. and then you put the medication in the joint. And like I mentioned, most commonly it's a combination of a local anesthetic and a corticosteroid. The local anesthetic to provide more immediate pain relief. There's also, some diagnostic value when you're looking back and seeing these people for a follow appointment of how good was that relief in the first 24 hours or so when the joint was numb. And then the steroid would be to provide the therapeutic relief for to see how long it's going to work for. So typically, you want to see SI joint injections lasting at least 6 weeks to be worth repeating. Ideally, 3 months or more. Typically, you can do up to four of these in a rolling 12-month period. So, while a lot of times insurance coverage will allow you to repeat it if it lasts for at least greater than 50% relief for at least 6 weeks, the practically speaking, if this is going to be a therapy or a treatment option you're going to want to continue to offer your patient on an ongoing basis, I think you'd want it to last consistently at least 3 months or so, because if they can only, get four of them in a year, and realistically, you don't want to be injecting steroid all the time in patients either. Um, you want to make sure that they have a pretty even treatment plan. When their pain starts coming back, they can get a treatment scheduled and done. They don't have to have some roller coaster up and down of their therapy of 6 weeks of pain, 6 weeks of relief, 6 weeks of pain, 6 weeks of relief. That's not a great way to live. And then, last thing I'll mention is kind of the difference between a diagnostic and therapeutic. Just to kind of, I think I mentioned it briefly, but just to drive that point home. A diagnostic injection of the SI joint will only have local anesthetic in there. And so you're going to want to see at least 75% pain relief for the duration of local anesthetic, which can be several hours, potentially up to like 24 hours. And then the therapeutic injection is including steroid in the injection. That steroid providing the lasting relief for the injection. And then this podcast is really focusing on the basic procedures here, but when SI joint injections work but don't last long enough, then potentially that patient could be a really great candidate for a sacroiliac joint fusion, which we'll potentially talk about in a future episode. And then the other procedure that if you're listening to this as a podcast and not as a short, we previously talked about radiofrequency ablation, and that can be done for the SI joint as well. But unfortunately, that has become a much more difficult procedure to get approved by insurance. But some patients, they can still get that so there are definitely other options, including peripheral nerve stimulation and other targets, the procedures that can be done for the SI joint if these SI joint injections aren't working and lasting long enough. All righty. Well, with that, we're going to wrap on SI joints and take a short break. All right, we're back on Premier Pain Talk. It's Dr. Michael Danko still with you here. We're going to have a real short little segment talking about two very common procedures that I think a lot of people know about and that probably won't require a lot of explanation. I'm going to talk about small and large joint injections. So a large joint injection, you're typically talking about bigger joints, so shoulders, hips, knees, and what you're doing there, basically injecting most commonly local anesthetic and corticosteroid in the joint, trying to reduce inflammation in an arthritic joint. And then you're going to see how long those last for. A good joint injection, I think you want to last for at least 3 months or longer. And then if they're not lasting long enough, then you might want to move on to another treatment option. In the knee, sometimes these are viscosupplement injections. Move on to it. And then for the other joints, big joints, you can move on to radiofrequency ablation, or you can send to the orthopedic surgeon to see what kind of surgical options the patient may have. With joint injections, these are most commonly going to be for arthritic conditions. There are other issues like subacromial bursitis in the shoulder and bursitis in other joints and other kind of areas that can be injected in, within that joint. But ultimately, this is going to be mechanical pain. This is going to be pain that's generally worse with using the involved joint. The kind of outside the scope of this podcast, but you can do some self-study on the different physical exam techniques for the large joints, looking for abnormalities in the shoulder and the hip and the knee. And then as far as small joints or medium joints, and this will kind of catch the other ones. You're talking about ankles, we're talking about elbow, you're talking about joints in the fingers and the hand, the wrist, for example. The like number one most common joint that people get arthritis in is their metacarpal phalangeal joint in their hand. So where the wrist and the kind of like right at the base of the thumb, where those two bones meet, that's the MCP joint. The first MCP joint is like the number one reason people or number one joint people get arthritis in, which is might be expected because people use their hands all the time. Uh, and so generally the major difference with small joint injections is the volume of medication you can inject is much, much less. So these joints are small. They don't have enough room in there to really put like 5 cc's of medicine in there like you might do in a large joint. You're going to potentially be using a little less steroid and or a little less local anesthetic to make because as you fill up that joint, it's not going to accept much more. And then as far as the large joints, a lot of times people will use some image guidance. So X-ray guidance or ultrasound guidance is common. For smaller joint injections, image guidance is sometimes either too tricky or not necessary. But as far as joint injections, just to recap, you want these to if they're going to work well for the patient, you're really wanting the steroid to do the work, and you're wanting it to last for 3 months or more to make it worthwhile, worth repeating. And then if you either get declining relief, so each one is lasting less and less, or it just doesn't work at all, then they need to escalate to a more advanced therapy option for the patient. All right, with that, we're going to transition into the very last injection we're going to talk about, and that is trigger point injections. So, one of the most common injections, and probably in all of medicine, is a trigger point injection. This is a intramuscular injection. There are varying degrees of how trigger points can be done. Sometimes I think you'll hear about physical therapists doing dry needling, which is, I guess, a variant of this. And then, when you're doing the trigger point itself, then sometimes people will just put local anesthetic in their trigger points, and then kind of use more of the mechanical breaking up of the muscle with the needle and the local anesthetic. And then the other option is to include steroid in there with the local anesthetic and try to provide some additional relief through the steroid. This is a muscular injection, so you're trying to identify which muscles are causing the pain. And then you're going to be injecting these muscles, potentially doing a little bit of manipulation with the needle to break up the spasms in the muscle. And then I generally have a staff member massage the area for a little while afterwards to try to loosen the muscles up further, spread the medicine around a bit. With these injections, you're wanting to have an adequate duration of relief to continue to repeat them. There's not really a lot that you do as far as physical exam and image guidance for this. But once you've identified, based on your exam that you think these are the muscles that come from, you inject them. You want to see them the injection lasts long enough, and then you potentially repeat. Trigger point injections were under a lot of scrutiny recently by regulatory bodies in terms of frequency of use. And I think in pain management, if you're a pain management specialist, listen to this. I think some of us had some confusion on why this was being looked at, because I don't think a lot of us do a ton of trigger point injections. It's a common injection, but a lot of times we're doing all the other procedures we do in pain management. But when you're talking about some other specialties, they were doing a lot of trigger points, and I think people were getting trigger point injections all the time. And so I think that's why they really ratcheted down the allowable number of trigger points and try to provide more definition on why you're doing it, what you're going to put in, how many sites you're going to inject, that kind of thing. And oftentimes nowadays, you can only get approval for 3 trigger point injections in a 12-month period. So, if you've ever heard of anybody saying that, oh yeah, my doc was doing trigger points every 2 weeks, I think that kind of practice, and that, realistically is probably what led to the ratcheting down on allowances and more specificity on how it's working before you can get future treatments approved. And I really think that's very appropriate. So, we In interventional pain management, we have a lot of tools at our disposal. So as I wrap up this episode, we talked through epidural steroid injections, we talked through medial branch blocks, facet joint injections, radiofrequency ablation, and all the targets we can do for that. Sacroiliac joint injections, small and large joint injections, trigger point injections. There are a lot of basic interventional options, and I haven't even touched on some of our less common procedures we do. But so there's really no need to ever be doing the same injection every week or every 2 weeks or something for a patient. Because if that's the therapy option, then I think the scope of treatment is way too narrow and need to take a step back and figure out if we can find a more durable solution for the patients. So I'm gonna hop right off my soapbox and I'm gonna close up this episode. I'm Dr. Michael Danko. I'm Premier Pain Talk. This is my private practice is in Cincinnati, Ohio, Premier Pain Treatment Institute. We have four locations on the northern and eastern sides of Cincinnati. I have Loveland, Ohio, Mount Orb, Ohio, Hillsborough, Ohio, and Middletown, Ohio. Our website, if you want to learn more about these procedures, is www.premierpaintreatment.com. And thank you for listening, and I hope you learned something today.